Thank you very much, Mr. President, Chairman, and the opportunity to present today. And I hope that it's coming through reasonably clear. I'd like to present today to my esteemed colleagues and delegates our thoughts on TAVI explantation, techniques, and pitfalls. In terms of what the story is, and we'll take a look at surgical and TAVI outcomes in the United States over time. We are seeing an increased risk, increasing rise of TAVI, of course, that's been exploding and taking over. And I think all of us as surgeons have been very supportive of that program. Now, in the American College of Cardiology recently in 2020, they looked at 132,000 TAVI cases, and to frame the problem, it's not very common. It's not very common for a number of reasons. One is many of these patients were considered very high risk for original surgery. They may be prohibitive candidates for surgery, but we see in this large population, about 0.2% of people underwent surgical explantation. 30-year mortality, about 13%, 1-year mortality, about 22%. But again, this is in a population at 76 and 83 years of age. One of the things that we have to ask ourselves is, as TAVI enters the mainstream of cardiology and structural practice, will the very restrictive guidelines that have been used in the PARTNER 1, 2, and 3 trials live in the real world? So we may be faced with an increasing number of patients that require surgical intervention after their TAVI as the real world takes over. What are some of the reasons that we may be asked to explant a valve as surgeons? Well, there's certainly structural valve deterioration. That may be depend really at the age at the time of implant. And of course, the program's duration. In the first couple of years of a TAVI program, there are not going to be very many. There may be acute complications, unfortunately becoming less and less, such as aortic root complications with annular rupture, embolization of the valve, or malpositioning of the valve. Of course, then there's endocarditis. This is an example of a patient with prosthetic valve endocarditis. We can have a look at the prostheses here. It's a large abscess around this prosthesis, and really there's no percutaneous option. What are the, in terms of endocarditis of the valve, the pros are it's easy to remove. The infection usually destroys all the tissue. And the cons are that, in fact, it is easy to remove as the infection destroys all the tissue. And we as surgeons intraoperatively are stuck with, there's sometimes a very challenging reconstruction. This includes all the challenges of endocarditis surgery, which my esteemed colleagues will be well aware of, root abscess destruction, the whole issue around the conducting system, and trying to reconstruct the annulus and the root with radical debridement. And essentially all the same principles that we would observe during endocarditis surgery, with radical debridement of all infective tissue, those principles have to be respected, and then the reconstruction started. What are some of the challenges and considerations in this? Well, obviously the comorbidities. The reason for the TAVI was usually for a high surgical risk, and even with the PARTNER 3 trial and the new trials on the low surgical risk patients, we have to remember that the average age of those patients in those trials is still 73. So they will be at risk for surgery. And when they're coming and they're sick, either endocarditis, a prolonged aortic stenosis, etc., we may be stuck with morbidities. It may be a redo status as valve-in-valve becomes more frequent. You know, our surgical paradigm right now is to place a early surgical valve or a TAVI valve. We're looking at that, whether it's valve-in-valve or a redo SAVR. That's certainly obviously a very interesting thing for consideration and discussion on lifetime management of patients' aortic valve disease. There are all the surgical considerations of the aortic root. Once you have this removal, and if there's destruction of the aortic root, you have to be prepared for full reconstruction. In terms of the surgical exposure, we'll have a few more things. I've done the redos and done them through a full sternotomy. Mini sternotomy is certainly possible if it's the first time around. depending on with femtime bypass. The redos, we still traditionally will expose the femoral vessels for peripheral cannulation if needed, and then one on Monday. Usually it's not, we're pretty facile as surgeons in getting in, even on redo sternums, but when you do hit that right ventricle or right atrium, then it's nice to have a fast way to get on. There's nothing about myocardial protection. I think that depends on the program, the degree of insufficiency of the aortic prostheses. We're currently using a Del Nido solution, either retrograde or antegrade, with a warm Buckford terminal shock. The aortotomy, that becomes a little bit of a technical issue as we'll go through here. And I think all these people, all your patients should have had a CT scan and you will know the type of valve. Once I am in small aortic roots, I'll make an oblique aortotomy in preparation for aortic root enlargement. Otherwise, my go-to has now become more of a transverse aortotomy. Everybody will recognize this. This is just a native valve, and it's standard tricuspid calcified valve. But that's not what we're going to deal with the TAVI. We can see here that this is the deployment here of a sapient valve, and you can see that here with the balloon expandable valves, they're very low profile. They're going to sit below the coronary arteries, so you have a fair bit of aorta to work with. Standard cannulation is quite reasonable, and an aortotomy can be performed as your preference. This is what it looked like when they come out. Once you've made your aortotomy, then you'll crush it between two clamps, and the valve will pull out. Surprisingly, even after they've been in for 3-4 years, they peel away from the annulus, unlike a surgical valve where you have to use sharp dissection to get them out because of the pledgets. If the aorta is small, then the struts can become incorporated into the wall, and they have to be peeled away. As you can see, some of the endothelium of the aorta is there, and you'll have to make an assessment really whether the injury is sufficient to warrant replacing either by a patch or a local reconstruction the aorta, or whether the entire aortic root needs to take place. The balloon expandable valves are slightly different and more challenging. As you can see, when the the self-expanding valve is placed, this one is placed lower than is an old slide, so we would place them literally at 0 degrees now but they will ride very high in the aorta. So there, based on the CT scan, you may have to make a high aortotomy, and that would mean then a change in cannulation strategy up into the transverse arch. Once you pull these things out, of course, this is what they're going to look like with the expanded cage up on top. This can really incorporate itself well into the aorta and can be very challenging. So the ascending aorta it can be very difficult to deal with. And then if you make a very high aortotomy, then of course the surgical valve implantation is challenging. Fortunately, we have a core knot, but trying to place the sutures, get a surgical valve in, get it well tied down can be a little bit difficult. So in the self-expanding valves, the problem is they keep self-expanding. Every time you grab them and you lose them, they keep on they keep on popping open. So you've got to you need to grab maybe 2 to 3 collapsing clamps, any kind of heavy clamp, Roberts type or big Kelly clamp, and then you'll peel them slowly away from the aorta. And then again, they will pull up. These TAVI prostheses don't really grow into, so they don't really require much in the way of sharp dissection. The challenge is the length of the prosthesis and the greater invasion into the aortic wall, so there's a higher incidence of aortic replacement. In terms of what, once it is done, most often these patients are candidates for tissue valves, and what we'll plan to do is to preferentially use a pericardial valve. While there are composite pericardial valve or tissue valves and the Dacron grafts available, I just will construct one. In general, a pericardial valve, the graft is going to be about 3 millimeters larger. So if you size a 23 valve, you'll end up putting a 28 graft. Sorry, it would be a 26 graft or 28 graft on it. the valve will sit inside. I use a Valsalva graft. You can put a stitch around, a little just non-hemodynamic stitch just to hold the valve in place in the Valsalva graft, and then a series of then a standard Bentall placement here. This is actually using a stentless route, which become to use more and more. Now, if there's only segments of the aorta that need to be replaced, you can replace it either with a portion of a freestyle graft or Dacron, as might be your preference. Many times, if the aortic root has really been damaged, we published a technique we call the inversion technique, and this is useful in small aortic roots or in redo procedures. We'll actually invert the stentless prostheses and put it into the ventricle. Then secure in 3 spots the prostheses. So you're looking into the ventricle here. This makes this a very easy over and over suture in here. The prosthesis is not in your way, 4 or 3 prolate, and then you pull this thing out. Matter of just aligning it so you can see the coronary button of the porcine graft is here. You can see the RCA here, and the left coronary is there. The final result will be something like this with a freestyle prosthesis and a Dacron graft added on to that as is necessary. Now, there's all sorts of complications that will be all sorts of other scenarios where we may be called upon to intervene. Here we can see a valve in a initial self-expanding valve with a balloon expanding valve within it. If this ends up coming to surgery, then you'll end up needing a combination of techniques to do. And essentially what I would advise my colleagues is, this is just like, if you know American style football, they use the term open field running. So once you're in there, you'll just have to figure out how best to do this. You can imagine an aortotomy that's going to be above this self-expanding valve, then taking all this out and working in a route that is 35 or 40 millimeters below your aortotomy. Our CCAD experience to share with you, we've done 500 plus TAVRs in the last 8 years, with most of our volume being in the last 3 years. We've only done 5 surgical explants at that time, and 4 of those had been some TAVRs done at outside hospitals. Our experience had been, there was one self-expanding that had acute embolization. That was at our institute. We recovered the device, a patient under cardiac arrest, and the patient went on to have another full aortic valve replacement. We had a balloon expandable valve with valve and valve, and then had a second valve and valve TAVR, also because stenotic been done in the US. We recovered, and then CC's stentless route was done. Balloon expandable valve paravalvular leak, again, Bentall procedure was done. One with endocarditis for pericardial annuloplasty with aortic valve replacement. And then there was one that had paravalvular leak that really was at inception. The patient came to us about 6 months after the initial implant, and we removed it. He ended up having a stented valve after the explant. Summarizing, explants in elderly patients is unusual because from structural valve deterioration. We know that the 8-year survival of a well-implanted TAVR valve is actually quite good. We end up seeing what happens thereafter. So far, we don't know what happens in very young people with this. We had a recent structural heart conference that tried to answer this question, that as the trials are over and the real world starts, if these valves are now being implanted in people in their 50s, and unfortunately maybe even in lower, then the deterioration rates are going to go up. I think some of our cardiology colleagues still don't appreciate that the fundamental biology of a tissue valve in a younger patient population is different than in an older patient population. The risk of explants in this population, if you do it in an elderly, is about 15 to 20% mortality or major complications. It's technically challenging, and you have to be prepared for advanced reconstruction of the annulus and aorta. All your prostheses, devices have to be available. Very high risk if it's an acute root complication. Fortunately, they become less and less with the better sizing, CT scan preparation, and the prostheses available to us. But an acute annular rupture is very challenging to repair, and will demand a surgical team on site We're likely to see an increased need in surgical interventions after TAVI, because I think that the reality is this will extend to not only lower risk patients, but patients who will be getting a consumer-based strategy rather than evidence-based one as time goes on. To thank the organizers for the opportunity to present, and very delighted to hear the previous talks, and we'll wrap that up. Thank you very much for your attention.
Thank you, one of my